Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast brought to you by RipsyTech. You are joined by RipsyTech product manager Parker Anderson. And as always, I am joined by the RipsyTech founder and CEO, the effervescent Tom Tarshis. Hi, Tom.
Hey, Parker. That was from my sparkling water drink that inspired
the bubbly spark. Yeah. I kept you on your toes before this on what that word was going to be.
I liked it.
Well, thank you. So this week's episode, we wanted to continue the conversation from last week. We started talking about open notes, did a little bit of history of the concept of open notes, why it started, and maybe some of the response to the initial reaction to the concept of open notes. And we want to kind of keep that ball rolling. So before I get into some of the questions and any kind of opening thoughts that you would like to provide to the audience.
Yeah, it's such a big topic, and because I was pretty involved and up to speed, coming up on 4 years now when Open Notes was just going live, and hadn't been following things too closely over the last few years, but in preparation for the podcast did sort of re-up seeing what's been happening and comments and looking at recent research. And, interestingly, there really hasn't been peer-reviewed research or even non-peer-reviewed research in massive quantities that have come out on Open Notes since 2021. And so, in my mind, I've just been sort of thinking, what do we make of that? There also hasn't been headlines on lawsuits, legal action, anything like that. And I think the general take from that is that even though this idea of, patients seeing their notes maybe instilled some fear in all clinicians, and maybe that's just because of some aspects of our legal system and general fear-based warnings that are actually not that common in mental health. But yeah, there just hasn't been a ton of research or other news, that has come out. And I think it's because it really hasn't been a drastic change in too much or in anything, or nothing awful has happened. Nothing great has happened because of it. And I think that's why we haven't seen too much over the past few years.
So, yeah, that's very interesting. It sounds like, that impression that it would kind of have a larger impact was perhaps, due to some initial misconceptions or, myths, or just, stories that the industry or the space might have been telling themselves about, what would happen if X happened. So let's maybe dive into that a little bit. Like what do you think, the myths and the misconceptions were, and, I guess how might we debunk them, especially given, this seeming outcome that we're talking about?
Yeah, and I do think it's worth pointing out that there are still lots of providers that, their patients don't have easy access to the notes, and especially in mental health and in smaller groups and private practices. So there is still, I think it's an important topic and worth some discussion, because there are still a lot of mental health providers whose patients don't see their notes on a regular basis. So there is still a large number of people wondering what's going to happen when that information is revealed to their patients. I did find a study going back, to 2021, where at a children's facility on the East Coast, they enlisted psychiatric providers and adolescent health providers as well, where they were looking at, giving access to 13 to 17-year-olds to their own medical records, including some perhaps sensitive information. And it was the same kind of anticlimactic findings, that it was maybe helpful for some of the teens to understand what had happened at the pediatric appointment or the adolescent health appointment. That information, there were some complications in how they store that information, because they want it so that parents have access to confidential information. So maybe like appointments or billings or general recommendations for care, but not any sensitive material. So that created some challenges for people documenting the notes, that either you could click the checkbox to not release the entire note, or, they sort of wanted their providers to do this dual documentation where you have one set of documentation that was sort of, general, not highly sensitive, and then you're putting sensitive comments into like another area that's separate. But then that created a lot of burden on the providers, and people just didn't do it. So, that's more of a logistic issue with technology. How do you save information and allow access? But I think the reality has definitely been that even with the release of psychiatric or mental health notes, it hasn't been a huge problem.
So something that you and I talked about when we were trying to come up with questions for this episode, and it's kind of the beefiest question that we came up with, was talking about, what might the sensitive situations be when documenting, the visit with the patient. How do you balance being transparent while also documenting something sensitive, like your sexual abuse or psychosis or substance abuse, and and the patient who you're treating for that is able to read that, and maybe they don't quite understand what that means, or maybe this is their first time ever seeking mental health treatment, so they're not familiar with the clinical terms and the diagnoses and what this means for them. So how do you as a provider writing these notes, how do you balance all of those factors?
Yeah, and maybe we could spend a little time on each of those. I think the psychosis one is interesting and a good one. Let's maybe tackle that one first. And
okay.
So let's pull up a patient scenario, and a typical patient scenario might be, someone's coming in to follow up for an appointment. It could be someone that's already been engaged in mental health care, and the psychosis piece is a new symptom, or it could be someone that it's their first visit and they've gotten under some court mandated care, or because of family threatening to kick them out, they've said, you've got to go see a psychiatrist because the stuff isn't real that you're talking about. So when you have a patient coming in, and if we go with sort of very common delusional processes, which could be like, people working at this gas station down the street have put transmitters in my brain. And I know this is the case because the first time I heard, radio in my head was when I walked by the gas station, and then it sort of continued since then. And I've seen lots of patients who have similar type presentations. So you've got someone with a very strong fixed belief that, if you say that's definitely not true, you're psychotic, that you're very likely to just lose that patient. So, the goal for this treatment is to build rapport, see if you can connect on other aspects of life not going well, and see if you can have a discussion about medicine that, can not only help with potentially the psychotic process or removing auditory hallucinations, but could in general help with other aspects of life. So say you manage to engage with a person well enough where, you agree to disagree on whether or not a radio transmitter was put in the brain, but there's enough buy-in around, yeah, my parents are angry, I dropped out of school, yeah, I haven't been able to get a job. And so if you have someone who's engaged enough around the process that things aren't great in life, and you want to prescribe a medication, traditionally in notes maybe 20 years ago, a provider would write, patient is acutely psychotic and has all these false beliefs, and we need to get antipsychotics started. And you can imagine if someone were to read that, that would be very damaging for the relationship with the provider. So with open notes, the strategy for the documentation is being very specific about what the patient reports. The patient reports a belief that, people at this gas station put a radio transmitter in his head, and he knows this is the case because it started when he walked by there. And then you can write, we agreed to disagree on whether or not this was true. However, we were able to connect on problems with job functioning, frustration with parents, and that there might be medications that could help with overall functioning and make improvements in the patient's life. And after a discussion regarding the medicine, the patient was willing to give it a trial to see if it made their life better. And so it's sort of avoiding calling someone psychotic or calling something a fixed delusion, but more specifically, just document the actual, what was reported to you. You can certainly mention that the agree to disagree, or saying, I told the patient that I wasn't sure this was true, but we were able to connect on these other items. That's less likely to do anything damaging to the relationship, is still honest and accurate, and it avoids putting in terms that could hurt rapport. Sorry, I feel like I spent a lot of time on that.
No, that was really interesting. I was just listening the whole time. So that statement, the agree to disagree, is there? Yeah, my own curiosity is wondering, like, is it important for you as the provider that you include a statement like that? If you're also kind of like giving the subjective reporting of, of what the conversation was about.
Yeah, I think, it depends on what happens in the session. So, there might be times with the patient where it feels easy to say, I'm concerned that if the conversation was, I'm concerned that didn't really happen. And there is this disease called schizophrenia where you have too much dopamine that can create real hallucinations. And then if the patient responds to that with like, there's no way, no, this is real. And then in the session you come up, well, let's agree to disagree on that one. And let's talk about then then that would be a good way to sort of put in the session that you did, gently challenge the notion of what's causing the psychosis, which as a provider, I do think is important to document. All that being said, there were also times in the past where in the note you would literally write, did not challenge patient on the disease state for fear of damaging rapport, but you wouldn't put that in anymore with open notes because they would read that. So just documenting factually whatever your response was to the patient is a safe way to put it in the record. And whether it's, well, let's agree to disagree, or, let's come back to that next session, or, would you still, I'd love to follow up on the symptom, however it happens in the session, just documenting that specifically, if that makes sense.
Yeah. Makes plenty sense. I guess let's move on to, the three that I mentioned were psychosis, sexual abuse, and substance abuse. So how about I'll let you pick which of the remainders you want to cover.
Yeah, and I think
first?
let's go to the sexual abuse or trauma of a sensitive nature topic next, and there will be varying opinions on this, but in general, for cases like this, I think there's no need to be very specific about information that goes in the medical record. I also think it's important to, in order to build that trust and confidence, is that you should have a discussion with the patients about, what documentation happens after a medical visit. And sometimes there'll be people who very clearly say they don't want, details or information written in their record about past abuse. And in general, my approach is that you can document that some sort of trauma or abuse happened while leaving it very general with no specifics. So, for example, if someone's talking about a sexual assault that happened when they were a teenager and now they're adult, it's very easy to document that, spent time discussing information from patients past that has a profound impact on how they're doing over the past 6 months. Or, if it even saying spent time discussing former traumas, which will be an important part of treatment to come. And I really don't believe in putting, you don't even need to specify sexual abuse or molestation or any of those details, that you could still document what happens in session and what you're working on without putting in any of those details. And I really stick with any type of abuse or trauma being as general as possible so people can understand what's happening with the treatment and is the source for current mental health symptoms, but without being specific.
This might be a little, I don't know if it's heavy of a question, but would you say kind of the same style of note writing applies to the situation of child abuse, or how would that work if it was also related to, you mentioned the cutoff of parents not being able to see the notes anymore is like 13 to 17. How does that work when they're maybe younger and the parents have access to the record? But clearly if the child is reporting abuse from a parent, then there's CPS and everything that also needs to be involved in that situation. But yeah, I guess when it comes to the note, and access to the note even, how does that work?
Yeah, and that's a great question, Parker. Right, and nothing should be too sensitive or off limits. As you mentioned, like abuse of a minor sort of falls into this other category where there are mandated reporting laws if you're a mental health professional or a teacher or. So in all of those cases, you're going to need to do other documentation. You're going to need to file a CPS report. Now, it is not necessary to put the CPS reports into the patient's medical record. And so the medical record, it is relevant to document when you need to file a CPS report, but you don't necessarily need to put those details in the medical record. And, for the clinics that I ran, whenever a CPS report had to be filed, the first thing you would do is the best practice is always to tell the people you're filing the report against that you are filing a report. And, whether or not someone gets angry about that or disagrees, it's much better that they're aware that you're filing a report than they find it out from a phone call or visit from CPS. And
Right.
and in experience, explaining mandated reporter that the requirements to report anything suspicious of abuse and this is why the report's being made, and having a discussion about it. There hasn't, in almost 20 years, there haven't been bad outcomes as long as it's been discussed with the people that, this is kind of specific for relatives, but it's also specific if you were going to file a report against a teacher at a kid's school, that you would want to let the parents and other people know that this is coming. So the medical record piece would be information was disclosed that, requires a mandated CPS report, which will be filed, but you don't need to say more than that in the medical record. And then we would store the CPS reports in a separate secure place, so that it was not part of the medical record. So specifically, right, if for that case that you mentioned, if you have an 8-year-old that even if you let the parents know you need to file a report because, they hit them with a belt, you don't want that parent to pull up. You could certainly mark the note confidential and explain why and other items,
Right.
but just cleaner to keep CPS reports out of the medical record and separately stored so that if it does come from a subpoena or legal hearing, you can still pull up the information, if that makes sense.
Okay. Yeah, no, that was, I mean, this has all just been really, really interesting to talk about. So let's, last but certainly not least, on that list that we were discussing, we have substance abuse. So how might the dynamic play out there?
Yeah, and lots of times with substance abuse, there's, from a patient perspective, discussing honestly their substance abuse, there's this, maybe some fear that, an employer is going to see their records or, someone else is going to hear about it. And so they don't want to actually acknowledge the level or extent of their substance abuse. So having that conversation about, again, not going to be putting very specific harmful information into the medical record. We're going to talk about the substance use in terms of, there's an addiction here, you're aware of it, here's our strategies for addressing it with medication and therapy. And then we'll sort of talk about things are same, better, or worse each week and what other strategies we're going to try, without relaying specific information that could be damaging if anyone got a hold of your medical record. And then also trying to allay the fears about, people will not, there are a few cases where people can get your medical record, disability insurance, life insurance. It's not really, no one can, and no employer can grab your medical record and use it as grounds for not hiring you or any sort of disciplinary action. But so that's one aspect of working with people with addiction issues that usually goes pretty smoothly. I think the other part of substance abuse that there's a lot of documentation about is what about when you have someone coming in who's maybe deceived you regarding, this is less likely now with drug databases, but someone was getting, say, narcotics from a different provider, and then they're coming to see you, getting narcotics from you, and perhaps you've been notified from a pharmacy that, hey, did you know your patient just got a prescription filled at, the pharmacy across the street 2 days ago from a different provider. So then, if you need to have that conversation in session with the patient about, it seems like you had a prescription filled somewhere else, that can get very heated, defensive, calling you a liar. And in that case, it's falling back again onto kind of being very specific about what happened in session. So spoke to patient X about the phone call I received from the pharmacy saying they had also received medication from another provider. Although the patient denied this, I did have a discussion with the patient about the dangers of, not disclosing prescriptions from other providers, and that it, wasn't in the best interest to continue with that medication at this time. And then, if the patient storms off or whatever happens, you can sort of document that also. And then, including, we'll reach out to follow up, despite the fact the patient said they're never coming back, or just sticking with being very specific about events and avoiding putting things like, the patient was clearly lying, or any sort of judgment calls that you're making, and just stick to the facts of the session.
So we've been talking a lot about, with the dynamic of open notes that, this is opening up the patient to be able to read their own notes. But also, as we've been talking about it, there's kind of been this like undercurrent of like, there are kind of legal or ethical things that you might need to be keeping in mind. So with that, I guess what should a practice or a provider be keeping in mind in regards to confidentiality or managing risks from like any legal or ethical standpoint?
Yeah, it's a good question. And I think there's once you have sort of a login or access to your medical records electronically, other people can get your password and information to log in. So there is a conversation to be had about, does anyone have your password? Do you, recommending around patients keeping access to their medical records confidential and sort of general password and internet security? I think there are, interestingly, from a HIPAA standpoint, you don't need two-factor authentication or authenticator apps or very advanced features to be HIPAA compliant. It's sort of a username and a password. So making sure that you have a system that can enhance additional security or put up a firewall just around protecting patient records and patient information is an important thing to do. And and as you know, whether or not our clients fully like the extra step for our secure firewall at Ripsy, it's something we've sort of decided to do to help ensure that those medical records are never released. I think from a risk management standpoint, it's very important to have certain documentations around medication or safety issues. So, being very general about some abuse that happened 10 years ago doesn't work as well if you need to do sort of an immediate risk assessment around a patient's safety, in which case, general best practice is, to make sure you do the risk assessment in session and sort of, in mental health week, classify harm to self and others as low, medium, or high risk, and go through these sort of check boxes to say how we're thinking. And it's just important to do that documentation. I think if you're worried your patient's going to read that risk assessment that says, I think they're in the high risk category for harm, have that conversation with your patient about, which you should be having anyway, that if you're worried about someone and they're high risk for harm, it should be a conversation with the patient and making sure that you're documenting that in the medical record appropriately. It's we have some very specific ways that I like to sort of do some of that risk management documentation. And I think what Open Notes brings is, before we'd sort of do the documentation and it wasn't something that a patient would read, and it wasn't something that would probably ever get read unless, a bad outcome happened. So now that there is access to these risk assessments, making sure patients understand that, hey, if you look at this record, there is going to be this risk assessment in there, and this is why will prevent any problems from happening.
So we've talked a lot about, AI, the future of AI, and how it's going to apply potentially to, this industry, and AI transcribing services are kind of the big use case that everybody's talking about right now. So, if an AI is writing your notes and we have Open Notes, how might Open Notes evolve as, telehealth and AI driven tools are just becoming more of a commonplace part of providing care to your patients?
Yes. Let me get my crystal ball. It's such a great question, Parker. And I'd say
we all want to know the answer.
We all want to know the answer. I'm very intellectually curious about this. There's a lot of very cool and field changing things that can happen with AI. And there's some things that we're very excited about that we can do with AI. And what's happening, with AI services is you're essentially creating these full audio recordings and then full transcripts of a lot of clinician visits in all fields. Right now, the medical record just sort of contains, what's hopefully been something that's been reviewed by the clinician that's signing their name to it and is showing up in the chart. And what happens to these audio recordings or transcripts. Right now, that doesn't need to be a part of the medical record. So is there going to be some legislation that starts to mandate, saving one or, the audio record or the transcript and it being part of the medical record? I think unlikely, but who knows? In general, the biggest risk for anyone who's used AI note generation is that it is far from perfect. So, resisting that urge to be lazy about not proofreading what goes into the note and taking shortcuts to save time, which, in busy professional career lives on this most unpleasant aspect of job, it's very tempting that, hey, AI just filled in all the fields. I can just click save and sign, and why bother reading? So I think that's the immediate pieces. Don't be lazy around your AI generated note and make sure you read it and correct it. I do think it's also very important for patients to know if it's AI notes, because at least for me, it's not that hard to tell what maybe someone wrote personally versus the way AI writes medical notes. And then
go ahead.
No, go ahead, Parker.
Oh, I was just going to say, it's just, some food for thought is, thinking about future generations of providers who, the AI tools are hitting the market now, but, in just even a decade from now, and you've got people who are in school, maybe they're going to start school in 3 years from now, and these tools have been commonplace for a long time. I think you're talking about this idea of, make sure you review the note, because there might be some information that's wrong in there and you need to go back and make sure it's correct, and you need to follow these best practices, especially with how you're communicating information about what you discussed in session. But when you come into this field and this tool has been around for years, and people have been picking it up, but it's the I generation kind of conundrum of all the kids that grew up with social media, as soon as they were born, social media was already a thing, and now we're seeing kind of consequences of that, and now then Gen Alpha, we're calling them like Gen AI. I'm very, very curious to just see how that evolves over time.
Yeah, and I think it's a capitalist society, and it's also there's a lot of lawyers in the world, and will there be a point, on some level, it's going to come out that AI does a better job around healthcare for lots of different aspects of healthcare. And they're doing tests already of can AI do a better job of creating a differential diagnosis for patients, versus other clinicians. And, could it get to a point where, hey, FDA has fully approved this AI note service to where you don't need to review your note, because they've convinced whatever regulatory committee that they're actually doing a better job than what a clinician would say. So then does that mean that then if something bad happens, the patient now sues the AI company? Or, Or if you're using an AI note generator as a clinician and maybe you were a little sloppy and the AI didn't put in the risk assessment, even though it's there in the transcript, then are clinicians who are sued in turn going to sue the AI company for not putting in that information that would have protected them? Like what is going to happen or be the new norm?
There's a lot to think about there. I get concerned about, loss of critical thinking. But yeah, I would, the legal ramifications. Now that is a whole other can of worms. I do want to be mindful of time.
Oh, right.
Because I feel we could keep talking about this.
Yeah, let me just
really
throw the one other comment I can't resist is,
yeah, please.
People go out. There's the conception that clinicians or doctors are wealthy, so that lawsuits tend to go against the people who have money versus the people without money. Now, right, the AI companies are very flush with cash now. So that is the reality statement for, is the target going to shift from clinician X to AI company Y because they have the deeper pockets? That tends to be how the system works. But
very interesting. All right, let's before we wrap up, let's do a mental health business moment. What any updates?
Yeah, let's see. Well, working on stuff for Hawaii, updates there. I will say we had in just going back to the realm of confusing insurance, had the experience where for the first time, it wasn't very clear on an insurance card that mental health services were carved out to another insurance company. So usually if someone comes in with an insurance that itself offers mental health coverage, but sometimes they have carve outs for other companies, and usually on the back of the card, it will say for mental health services called this company. But it was an insurance company whose carve out is named suspiciously, and it wasn't very clear. And it created this issue that if you have the HMO version of this insurance, you get a not as good mental health coverage. And it was just another new 18 years into this, something I had never seen, where your average person could not detect it by looking at the benefits and reading the back of the insurance card. So now we've identified it and can watch for it, but it was a disappointing finding.
Well,
I was nice to not name the insurance company, I think, but maybe I should be naming them. But
well, yeah, with these mental health business moments, it's interesting because it's always a mix of disappointing and sometimes hopeful, or so yeah, interesting. All right, I will end things there. So thank you for joining us on this week's episode of the podcast, Sit and Stay podcast, brought to you by RipsyTech. If you're interested in applying as a guest on the show, send us an email at sitandstay@ripsytech.com, and we will see you in the next episode.
Thanks, Parker.
Thank you, Tom. I'll see you later.
Cheers.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.